the amount of knowledge and effort she's gained in this field. She's a unique resource in the field, and I'm just dazzled by the types of information she's gathered. And I've was lucky enough to see her presentation slides for today, and they're just amazingly rich with information that I don't know has ever been consolidated this well anywhere else in the world. So this is a real treat, and I look forward to hearing your talk today, Jane.
Thank you. David, thank you so much for the introduction. Hi, everyone. Thank you so much for joining. I know that this time is not perfect. It's Saturday mid-afternoon for US, and it's very, very late in Europe, and it's very, very early in Australia. So I really appreciate everybody coming. It's amazing to see so many people. We actually have 70 people sign up. So I hope that some people will come along, and probably some people will be just listening to the recording. So I'm going to share my screen. Okay. And so the topic of today's talks, I actually don't like to call it a presentation because I'd rather keep it as informal talk, and I'm really welcoming everybody's comments and questions in the end, is immunotherapy. You know, immunotherapy is a huge field now, and it's growing at the speed of light. So first part of the talk today, I'm going to dedicate to very high level, very basic understanding of how it works, what is actually immunotherapy. And then we'll talk a little bit about its role in the treatment of EHE, or at least what we know today about the treatment of EHE with immunotherapy. So I want to start with some basic information about inflammation and cancer. We always talk about how bad inflammation is, right? We always ask on Facebook about anti-inflammatory diet and how to keep inflammation down in a body. And it's true. It's very established knowledge that chronic inflammation increases cancer risks and actually increase cancer progression. And a cancer and inflammation is a vicious cycle, because cancer always causes inflammation, and this inflammation in turn push the cancer to progress. However, if we think about inflammation, what is inflammation? Inflammation is the response of our immune system to foreign objects that got into our body, such as microbes or infection or virus or cancer. So at the same time, whilst inflammation promotes cancer, we know that that's the same cells in our body that are actually trying to eliminate cancer. And depending on the circumstances, actually, the same immune cells can be either pro-cancer or anti-cancer. It all depends on the balance in the body of what we're going to call a bad inflammation and a good inflammation. Those two processes always coexist. But in progressing cancers, it seems that pro-tumor effect of inflammation always dominates. So today we're going to talk about good inflammation. And during this talk, you'll hear me saying that's good, the tumor is inflamed, we have all this inflammation in the tumor, and it's kind of counterintuitive, but we're talking about good inflammation. We're talking about inflammation that helps us beat the cancer, because the immunotherapy is based on this good inflammation and inflammatory cells that participate in good inflammation. Really short about history of immunotherapy. So even from ancient Egypt, there have been several reports of tumors disappearing after the infection with a high fever. And of course, it was a long time before somebody actually tried to do something about it. In 1891, William Coley, he was a physician at Sloan Kettering, New York, who is known today as a father of immunotherapy. He first attempted to harness the immune system. What he did, he injected patients with bone sarcomas, he injected them with live and inactivated bacteria to cause inflammation in patients' body. He caused a lot of fever in the patients. He actually achieved some durable responses in some cases. But because at that time, nobody could understand how it works, he was pretty much labeled as a quack, and nobody made a big deal of it, and they never let him to proceed with these discoveries. The existence of T cells and their critical role in immunity was discovered in 1967. So let's remember the T cells. The T cells is a type of lymphocytes. It's the cells of our immune system that's primarily responsible for fighting cancer. So let's just, for the sake of this presentation, there's many different types of cells, but we're going to focus on T cells. These are the cells that find and kill cancer cells. Around the same time, Lloyd Old, who also worked at Sloan Kettering, demonstrated that cancer actually can be recognized by body's immune system. At that time, it was clear that immune system can recognize viruses and can recognize bacteria. Lloyd Old demonstrated that cancer can be recognized by the immune system. In early 80s, James Allison discovered that immune cells are highly regulated and they have ignition switch and the brakes. His work led to the development of checkpoint inhibitors, which is now the most common type of immunotherapy. And in 2018, he received the Nobel Prize for his work in cancer immunotherapy. I can't help but to show off a little bit. You'll see my photo with Jim Allison. I believe it was 2017, one of the immunotherapy conferences. You know, Jim Allison plays in a band which consists of 100% scientists working in immuno-oncology. The name of a band is Checkpoint Inhibitors. He plays harmonica. And I remember I crashed their concert and I engaged him and we had a really great encounter. And that's the picture that I'm going to show to my grandchildren. So how exactly immune system, you'll just excuse me for 1 second, I'm going to try to move this. Okay. How does immune system recognize cancer or, for that matter, virus or bacteria? All normal cells in our body have a variety of proteins that tells the immune system not to attack them. These proteins are called self-markers. So when the immune cell, this is our cute immune cell, sees our normal cell, it recognizes the proteins on the surface and it knows, oh, that's one of us. I'm not going to do anything. But bacteria or virus or cancer cells have other non-self proteins. They called antigens. And when the immune cells see those antigens, which are non-self, the immune cells recognize the cells as foreign cells and destroying it. In many cases, cancer actually fool immune system by pretending that they're normal cells. And they just go, here we go, that's me, don't eat me. I am part of this body. Because very often we wonder if immune system can recognize cancer, how come we still get cancer? How come we still have progressing cancers? Let's keep in mind that cancer cells, not like bacteria or virus that enter our body as a totally foreign object. Cancer cells are us. They are normal cells, just underwent some transformations. So a large number of tools inside those cells are still the tools that normal cells actually using to prevent to be distracted by immune system, and cancer's taking a full advantage of it. So that's a very busy slide, but we're not going to concentrate on a lot of this reading. This is cancer immune cycle. So let's go over how exactly immune system recognizes and kill cancer. There's several steps in here. And the very first step is right here. The cancer cell died. I forgot to mention in my previous slides that one of the ways the cancer cell fool immune system, they hide those antigens from their surface. They have them, but they're inside the cells. So immune cells can't really see those antigens on the surface. And they totally think that this is a normal cell. But when the cancer cell dies, all those antigens just break from the cell. All the guts of the cell, all this insides of the cells actually go in the bloodstream. where they picked up by the immune cell called dendritic cell. It's this funny looking cell that has like tentacles or arms or legs. The dendritic cell picks up these antigens, process it, and present it to the T cells. That's step 3 right here. Remember, the T cells is actually the cell that will go after a cancer cell and try to kill it. I think I found a good analogy. Let's think about a police dog that was trained to sniff something that belongs to a criminal, and they go after the criminal, find him, and attack him. So let's think about the antigens that come out of a cancer cell after the cell dies as the criminal glove. And the dendritic cell is our police officer who picks up this glove and give it to the dog and say, go ahead, just sniff it and go find this criminal. That's exactly what's happening here. The difference is that after these T cells sniff the antigen, it gets activated. Now it knows that it has to find this very specific cancer cell, and it gets multiplies. So instead of this one cell, it becomes 10, 100, 1,000. A lot of those cells that are specifically activated, again, a very specific cancer cell, multiply in a bloodstream, go in a bloodstream and trying to find the tumors. They get to the tumor and they try to infiltrate the tumors. Once they infiltrate the tumors, they kill the cancer cells. Hopefully they will recognize the cancer cell, will kill them, and the cycle will start over again. This cycle is highly regulated. And what Dr. Jim Allison found is that each step of this cycle has actually gas and the brakes. There are processes that can either accelerate or amplify this step, or can put brakes on them, can slow it down, or even completely block. And what's here, I'm not going to go over this, that's a lot of stuff here, but what you see here is a demonstration that each step has gas. So those are the processes, the molecules, it's, you know, let's call them, it's something that will accelerate the process. And on the right in red, that's the brakes. That's something that will slow down or even block those processes. So immunotherapy is based on trying to utilize this, either to even put more amplification to the gas, push on a gas, or to take off the brakes from this process. So this whole cancer immune cycle becomes very efficient in finding and killing cancer cells. So let's see what might happen. Sometimes the activation of T cells is blocked. The brakes are on. So let's look at that's what's happening here. This is our inactivated T cells. And this is the dendritic cell. So this is our police officer, and this is our dog. And a police officer is giving a glove to a dog to sniff right here. And usually T cells will get activated and it will go out in the bloodstream looking for cancer cells. But in some cases, there is a break here, right here, which prevent T cells from activation. It's almost like this guy here who's holding the dog on a leash, right? So the dog cannot go there and cannot look for a criminal. Part of the immunotherapy that's called anti-CTLA-4 is designed to take the brakes off, to disrupt this process of inactivating T cells. Let's say that we just cut this leash here. So these cells activate and they're free to go. This is the type of immunotherapy that actually Jim Allison came up with. What if killing machine is blocked? So the dog is sniffed the glove, went out to the screen, actually found the criminal. And in this case, it's the tumor cells and it's the T cells that sniff the tumor cells, figure out, yep, that's exactly who I'm after for. And under perfect circumstances, the T cells will shoot this molecule, that's called interferon gamma, which will kill tumor cells. But remember, tumor cells are smart. They have the tools to prevent it. So very often they will put a muzzle on a dog's face, on a dog's nose. So the dog found the tumor cell and the criminal, and it wanted to attack it, but the criminal put a muzzle on a dog's face. So dogs can't do anything, can't bite, can't attack the criminal. That's what's happening here. And there's a type of immunotherapy that's called anti-PD-L1 that disrupt this process, that takes the muzzle off the dog's face. So the T cells can actually kill the tumor cells with interferon gamma. Let's remember this PD-L1 because later on in a presentation, I'll talk a little bit about it, what it means for EHE. What if it's not enough of this specific T cells? What if it's many, many cancer cells and just not enough T cells to kill them? There is a type of immunotherapy that multiplies specific T cells. It's called adoptive cell therapy. How is it done? So the tumor is resected from a patient, and tumor consists of many, many different cell types. So those cells are all separated and sorted out in a lab, and only T cells that can recognize this particular cancer are selected, and they expanded in a lab to thousands, sometimes millions of times, to many, many more specific selected T cells that go specifically after this cancer, and they re-injected back in a patient body. So now this patient has many, many of those T cells that go after cancer. Let's look at the other scenario. What if T cells don't recognize cancer cells? It happens. There is a ways to fight this too. There's a type of immunotherapy that engineers effective recognition. It's called Carti Cells. How is it done? The T cells isolated from the patients, just regular T cells, not specific T cells. And they engineered so they have a little piece of little molecule or a bunch of proteins here that are engineered, designed to recognize this specific cancer. So then these T cells are grown and expanded and re-injected back in a patient. What if T cells can't get in a tumor? So everything goes as we want, right? The T cells are activated. There's plenty of them in a patient body. They found a tumor, but they can't get in a tumor. It became a holy grail of immunotherapy because it doesn't matter what happened before that, right? It doesn't matter if the T cells cannot actually get into the tumor and kill cancer cells, nothing else matters. Scientists divided tumors in several subtypes. We'll start here from the right. So this is inflamed tumors. Remember, we're talking about how bad inflammation is. This is actually good inflammation. What we see here, this brown line is the border of the tumor. The brown dots here are the T cells located inside the tumor. And the brown spots outside the line are the T cells located outside the tumor. So we see it's plenty of T cells inside and right outside on the periphery of the tumor. This is inflamed tumor. This is immune excluded tumor. When we see good amount of T cells right outside the tumor, they're trying to get in a tumor, but for various reasons, they can't. There is no T cells inside. You don't see any brown spots here. Those are just tumor cells. And we have immune desert variation when there is no T cells anywhere, not inside tumor, not right outside tumor. There are various reasons of why it happens. And very often, there are various types of different treatments, different types of immunotherapy or other treatments that might be able to change this, to actually bring the T cells in a tumor. And our next slide will be dedicated to that. So it's been proven that combination therapies work much better than the single therapy, single immunotherapy, because some therapies actually prime tumors and prime circumstances where immunotherapy can work much more efficient. We know that radiation and chemotherapy kill cancer cells, right? Remember, once you kill the cell, all these antigens are pouring out, so it will provide more material to recognize cancer. Some virus vaccines produce a lot of inflammation, and inflammation actually helps to bring more T cells in the tumor. We're all very well familiar with anti-angiogenic drugs because a lot of EHE patients are on either pazopanib or bevacizumab. Those drugs are actually normalized blood vessels. Cancer blood vessels are very irregular, they're leaky. They don't really bring good amount of blood to the tumors, and tumors can survive on very small amount of blood. But when you try to bring medication to these tumors, it's very inefficient. So those anti-angiogenic drugs, they normalize the blood vessels, and this way they'll help to bring more T cells to the tumors. Cellular vaccines, like I showed you before, increase number of T cells in the bloodstream. And checkpoint inhibitors are designed to take off the brakes in cancer cell killing. So the combination of those therapies proved to be way more efficient than just one of them. I want to show you this graph. It's actually, I believe it's for melanoma patients. So vertically, it's the percentage of patients who survive cancer over a period of time horizontally. This first line, the purple line, is a control line. This is people who didn't have any treatment. So eventually, over time, most of this patient died. The next one, the blue one, is the chemotherapy. So we see that it's more effective because it takes longer time and more people survive longer. The immunotherapy, and this is a particular type of immunotherapy, at the beginning shows almost the same result. But then at some point, you see that more people live much longer. It provides more durable, long-term effect. But when you combine immunotherapy with chemotherapy, you get this reddish line. The effect is definitely much better. More people have effect, and they remain cancer-free or stable for much longer time. That's why most of the time now, when you look at the clinical trials, you see that with immunotherapy, most of these trials are a combination of several drugs. And that's my next slide when I want to, no, not next one, sorry, I'll show it later. So the next slide is, today's probably my favorite topic. It's intestinal microbiota. So, you know, we covered with microbes, inside and outside. Actually, what even blew my mind when I learned that only 10% of our gene are human specific. 90% of gene we share with microbes. So we can just consider ourselves a bunch of bugs. The intestines are the main location of hundreds of millions of microbes that form microbiota. The intestinal microbiota regulates the immune function of the body. And most importantly, it optimizes the therapeutic effect of immunotherapy. For example, oral administration of some microbes demonstrated significant increase in T cells infiltration in the tumors. Remember, we're talking, that's our goal. We want to bring as many T cells in the tumors as possible. And taking oral probiotics showed that it's possible to increase. In several studies, patients with good intestinal microbiota responded better to immunotherapy. And that's a question of what's considered a good microbiota, which hasn't been answered yet because those studies are ongoing. And as everything else is cancer, there is no single straightforward answer, because in some studies it was this type of microbes, in the other studies it was this type of microbes. That's definitely certain population of microbes make a difference for certain type of immunotherapy. So it could be said that the microbiota controls the cancer immune settings in individuals with cancer. And I want to show you, it's the result of a clinical trial for melanoma patients who were put, some group of the patients were put on immunotherapy, and some patients were put on immunotherapy and live bacteria called CBM588. I'm not sure what it is, but that's the results. You know, I just need to, sorry, I can't see my screen. Okay, so the patients who just went immunotherapy, underwent immunotherapy trial, they showed some response, and this response is here in blue, some stabilization and destabilization in beige, and progression of the disease, which is here in brown. But the group of the patients who were also giving oral live bacteria, look at the difference. This is how many patients actually responded comparing to here. It's a really drastic increase just by adding to the same medications, adding probiotics. Well, it's a specific type of probiotics. It's a live bacteria, but still it's a really impressive result. There's several strategies how we can improve gut microbiota. The most effective strategy is fecal microbiota transport. And it sounds really gross, but it proved to be extremely efficient. It all started with actually fecal transplant for patients, not for cancer treatment, but for antibiotic resistant bacteria. You know, some people, like for example, MRSA, this is one of the very hard to treat infections that people sometimes pick up in a hospital that does not respond to antibiotics. And doctors realize that once these people normalize their gut environment and they have a nice microbiota, they start responding to antibiotics. So when doctors and researchers started working on immunotherapy and cancer treatment, they started in mice. And they treated with immunotherapy group of mice, and some mice responded and some mice didn't respond. So what they did, they took some stool samples from mice that responded to immunotherapy, and they transplanted it to the mice that did not respond and reinitiate the treatment. And a large proportion of these mice who did not respond previously actually responded to immunotherapy. So then doctors and researchers did the study in humans, and they saw the same result. People who did not respond to immunotherapy after giving fecal transplant from patients who did respond to immunotherapy actually showed significant improvement. Not 100%, nothing is 100%, but it was a significant improvement. The other big part of how to improve gut microbiota is prebiotics in plant-based diet. We always talk about diet. We always talk about Mediterranean diet and plant-based foods. And it's been proven that it doesn't matter how much probiotics, how much microbes we're gonna ingest, unless we have fiber in our intestines, they're not gonna survive, because microbes actually live on fiber. They eat fiber. So it's very important to provide significant amount of fiber. And of course, probiotics. As I said, for different type of immunotherapy, there was different type of probiotics that shows efficacy, but the consensus is that multiple strains seems to be more effective. So if you're looking for probiotic, just look for a variety of different strains. And unfortunately, sometimes in some cases, there is also a bad, harmful bacteria that actually prevent immunotherapy from working. And if doctors figure out that some patients have overload of this bad bacteria, they treat these patients with antibiotics to kill this harmful bacteria. So there is actually a clinical trial going on now at MD Anderson that's called Diet and Immune Effect Trial, that aimed to test diet as a precision intervention in cancer, finally, right? with the hypothesis that the whole food-based fiber-rich diet will modulate the microbiome and enhance systemic and anti-tumor immunity. So they taken patients who had melanoma, but who had a complete response to immunotherapy. They cancer-free. And as a preventive maintenance, they putting these patients on a specific diet. They actually cook for this patient. They send them food. And they monitor these patients' biomarkers. They monitor what's going on with the intestines. They monitor their blood work. They monitor many different biomarkers. And then they see the outcome. They see how this specific diet, a whole food-based fiber-rich diet, affected the outcome. How many patients recurred? How soon they recurred? What were the specific immunotherapy biomarkers in these patients? So it's really amazing that now the mainstream oncology finally getting to recognize that food matters, right? In a couple of weeks, I'm actually attending a annual meeting of Society of Immuno-Oncology and Cancer. And I was thrilled to see that the entire day of this conference will be dedicated to microbiome, diet, and a cancer immunotherapy. So I'm really hoping to learn a lot from this. All right, so the first part, what is immunotherapy and how it works, is we're going to the second part, what it all means for us. What do we know today about immunogenicity of EHE? So first of all, the term immunogenicity means that how likely is that the patients who have this cancer will respond to immunotherapy. So we're going to use this term, immunogenicity, right? We know something from analysis of EHE tissue, because for other cancers, there are already some markers that can tell just from tissue analysis how likely this patient will respond to immunotherapy. And some of EHE tissue samples were included in those studies. So what did we learn? Several small studies determined that there are raw immune cells infiltrated in EHE tumors, but the average amount is rather modest. We'll talk about what it means, average amount, right? So we take a positive look at it, because it will be much worse if the studies will show there is no immune cell infiltrated. The EHE tumors are completely cold and they will not respond to immunotherapy. So it's a good thing that there is some amount of T cells infiltrated. Several large sarcoma studies demonstrated that there is some activation of T cells. Remember, the T cells by themselves don't mean anything. They have to be activated against a specific cancer. So there's some studies that demonstrated that there are activated EHE tumor cells in EHE samples. And the recent large sarcoma study from Sloan Kettering showed that some EHE tumors have a genetic signature that in other cancers associated with good response to immunotherapy. Those studies have huge limitations. All of those studies called EHE, EHE. We know there's no such thing as EHE. It's many, many cancers. We know that EHE in a bone has totally different biological behavior than EHE in a lung. And EHE in a pleura have totally different behavior than EHE in a liver. None of these studies actually separated patients by the location of the tumors, by high aggressive EHEs, right? We know there is EHE very indolent and the EHE very aggressive, and they should have some difference, but all those samples were put together. Some of those samples were analyzed by companies that were just doing genetic analysis. So they didn't have any data on whether these patients were undergoing treatment or they were on wait and watch approach. From everything that I told you before, it should make a difference, right? Because we know if patients are undergoing chemotherapy, maybe they will be more receptive to immunotherapy as well. So that's a huge limitations of those studies. Those average actually kind of meaningless for us. Like, recently a patient asked me, what is the survival time? What is the overall survival time for EHE patients. I personally know a patient who died 2 months after diagnosis, and I know the patients who lived for 38 years. So if you take all the patients and take an average, it's going to be, I don't know, 10 years, 12 years, depending on how many patients we're taking and depending who these patients are. But it's meaningless for each particular patient, right? Because we want to know where exactly this patient falls into what subtypes of EHE. What are the big limitation of this study? That the comparison was done with other cancers. And I'll give you an example. So the number that was called modest, that the number of T cells infiltrated in EHE samples was rather modest. In most aggressive cancers, or let's just say in aggressive cancers, by correlating number of T cells that infiltrated the tumors with the response to immunotherapy, they came up with certain numbers. And this number is about 50. If there is 50 or more T cells infiltrated in a tumor per 2 square millimeters, these patients most likely will respond to immunotherapy. We have no idea how many T cells are sufficient for EHE. Maybe we need 30, maybe we need 20. We don't know, there's no this data. So I look at this data as rather positive because at least we know that it's not completely cold, there is something there. And there is more studies needs to be done to figure out what is specific to EHE. What also makes me kind of positive and hopeful for immunotherapy for EHE, it's been determined in most cancers that immunotherapy is more effective on early stages before cancers become very aggressive. And the majority of EHE is not very aggressive. Of course, we have very aggressive cases, but the majority is not that very aggressive. So there is a hope that even progressing EHE, the slowly growing EHE, behaves more likely like early stage cancer, which offer a better chance of responding to immunotherapy. So I want to show you one of these studies, just one of the studies to give an example. So this study was presented at ASCO, and those of you who attended my previous presentation, I showed this study on the ASCO presentation. So there was a large study in sarcomas to determine the presence of certain biomarkers that will actually tell the doctors whether this type of sarcoma is immunogenic or not. There was 3,600 sarcoma patient sample representing 45 histologic subtypes. There was 24 EHE samples included. And as I said, they showed there's definitely some infiltration of certain types of immune cells with modest average amount. There's definitely some activation of T cells. The scientists who did this study, they assigned a score, an immune score. And the EHE score was not impressively high, but it was not very low. And I'll show you actually the poster that was presented. It's a very busy poster. We're not going to talk about any of those. I just want to bring your attention to this map. It's called the heat map. So the red, this is types of sarcomas. The red means that those sarcomas are probably immunogenic. They probably will respond to immunotherapy. The more red they are, the more red in this color, the more likely they will respond. The blue sarcomas are ones that probably will not respond to immunotherapy. And the denser this bluish is, the less likely they will respond. EHE is right here. This is EHE. So we see that it's not very, very red, but luckily it's not blue at all, right? It's definitely falls into immunogenic. And again, this is the average. We don't know out of 24 patients, how many patients had aggressive EHE, how many had indolent, how many patients had it in the liver, how many patients had it in the lungs. It's technically very possible that once we separate this, we might find out that EHE in the lungs is right here and EHE in the bone is right here. I don't know. Nobody knows. Nobody's done it before. It would be a huge help, right? If we know that EHE in the liver that's slowly growing, maybe right here, so the patient will know immunotherapy is their choice. Excuse me. This data has not been collected. What do we know about actual response of EHE patients to immunotherapy? Very, very little again. Last year, it was a publication, a review of several clinical trials in Europe and US that shows that 7 patients who were enrolled in the study did not show objective response. And it sounds upsetting, but I want to bring your attention to something. Almost all clinical trials call objective response actual shrinkage. And it's great to have shrinkage, right? And we're all hoping that EHE tumors shrink, but we know that very often they don't. And there are reasons for that, because they're very fibrotic. So even if therapy kills cancer cells, there's a lot of fibrotic tissue there that is not killed by treatment, anti-cancer treatment. The tumor remained the same side, but cancer cells are actually killed. But we know that they stop growing. We all cheer when we have stability. That's what we want. So these 7 patients, we have no idea how many of those patients actually showed stabilizations. Maybe none of them, maybe all 7 of them. The more recent study from Sloan Kettering actually reported stabilization in 4 EHE patients. So this is more definitive with immunotherapy. There are at least 6 published EHE case reports describing some response to various immunotherapy. I can't see there was 3 in the liver, 1 in the lung, 1 in the skin, and 1 in peritoneum. Some of this immunotherapy was old. Some of those cases were reported from Japan when they used immunotherapy that I was actually using now in US. So I didn't bother to provide all the links. If you're curious, you can PM me or send me email. I'll send you this information. We of course don't know how many of the patients did not respond, because we understand that when people publish something, it's something that was positive, right? Nobody's going to publish about patients who failed a certain treatment. In our Facebook group, I caught at least 5 reports of at least temporary response to immunotherapy. There was 2 in the liver, 2 in the lungs, and 1 in the bone. And 3 patients reported non-response. It might be more, of course, because unfortunately, we know when patients not responding to therapy and getting sick, not always they continue with the Facebook. So that's not very reliable data. But we know at least it's not nothing. There's several ongoing clinical trials now that enroll EHE patients. So hopefully soon we'll have more reliable data. I want to say something about the biomarkers. So it's all good, but is there any way we can tell which EHE patients will respond to immunotherapy? Those biomarkers were well established for some cancers, but they are not established for EHE. And I think it's very important for everybody to understand, when you making a decision and you're trying to talk to a doctor and ask him, what are my chances? Like, what from everything that you see in my genetic analysis and my molecular profile, is there something that will indicate whether I respond or not? Unfortunately, early on when immunotherapy just started, a lot of doctors would tell their patients, based on your genetic analysis, you're not a good candidate for immunotherapy. And it was not an accurate statement, because those assumptions were based on what markers work for other cancers. But couple more years, and now all oncologists know what is true for one cancer does not necessarily true for another cancer. I already gave you example with a number of T cells, right? We don't know how many T cells we need for EHE to be responsive to immunotherapy. Another example is PD-L1 expression. Now practically all hospitals and all commercial companies that are doing molecular analysis do PD-L1 staining. They stain the tumor with this marker, which proved in some cancer to be a good biomarker for response to immunotherapy. But we don't know what it means for EHE because nobody done any correlative studies. And even, I'll give an example. So the lung cancer has several subtypes. The most common lung cancer is called non-small cell lung cancer. And immunotherapy proved to be quite effective for this type of cancer. So a lot of patients were undergoing treatment, and the studies were done to see how this PD-L1 marker works for this non-small cell cancer, lung cancer. And they established that if you stain it for PD-L1 and the staining has certain numbers, hits certain threshold, this patient will respond to immunotherapy. But then when they started doing the same analysis for another type of lung cancer that's called small cell lung cancer, this PD-L1 marker was completely useless. People who did have marker didn't respond to immunotherapy, and patients who did not have marker actually respond. So the answer is we don't know. There is no way now we can tell which EHE patient will respond to immunotherapy or not. We need to do more studies. When your tissue is analyzed for these markers, if it shows those markers that are working for other cancers, it's probably increased chance that the patient will respond. But absence of those markers doesn't mean that the patient will not respond. We only can get this information by correlating various cellular and molecular features of each tissue with outcome, and that's what's done in immunotherapy trials. Only by doing this specific to EHE correlations. I want to say a few words about immunotherapy research, EHE immunotherapy research in oral lung cancer. So first of all, they have amazing collaboration of the sarcoma department with acclaimed immunolab. You know, Sloan Kettering has been on the front line of immunotherapy, well, since since William Coley started doing his vaccines more than a century ago, right? We were really lucky. A couple years ago, a private donor donated $1 million to EHE research to Sloan Kettering. And the EHE Foundation is trying to continue support of this work. The EHE Foundation keep awarding grants to Sloan Kettering, so this work continues. So there's a lot of work is done on EHE and immunotherapy and EHE at Sloan Kettering. One of the ways this money was actually assigned was to open up slots in clinical trials for EHE patients. Yeah, we have to pay for that. You know, not every pharmaceutical company will pay for EHE. So those openings are open for EHE only thanks to these donations and the grants that EHE Foundation awarded. And of course, today Sloan Kettering sees probably more EHE patients than any other institutions in the world. They have a very well organized database, more than 200 EHE patients. They have a large collections of EHE tissue, and all this makes research more attractive to Sloan Kettering scientists, which hopefully will lead to more definite results. You know, since we're here on a topic of grants and private donors, I want to really say, like, literally a couple sentences. I always feel uncomfortable talking about money and donations and fundraising at this type of settings. That's not why you came here, right? You came here to get information. But the part of me feels that we owe you this. We owe you this information, this understanding that unless we do something, nothing's going to happen. Last week, I took a flight to California and I flew Delta. And Delta proudly announced, you know, it's a breast cancer month, October is a breast cancer awareness month, that they have donated $21 million to breast cancer research. We can't count that any airlines will do this to us, right? We don't get much interest from big pharma. We get some, and the more studies we done, hopefully the more interest we'll get. But unless we do that, we're not going to get anywhere. So I just feel that it's important for me and for anyone to deliver this message to you, so you understand that all those questions that we're looking for, we know these questions and we're trying to address them, but the only way we can address them is we're going to fund those studies. So I'm uncomfortable, but you know what? When you come to the store and you see nice shoes and you ask a salesperson, how much are those shoes? And the person will tell you, I'm not really comfortable telling you. That's exactly here. You have to know that it's a lot of money and we need to raise this money. So next month is going to be Giving Tuesday. When we start asking you for donations, you know what we're planning to do with this money. Those are the list of, at least what I know, what I'm aware of, 4 clinical trials in immunotherapy that are open to each patient. There is 2 clinical trials in Sloan Kettering and 2 clinical trials in Santa Monica, California. And as I mentioned before, you notice that all of those trials are combination therapy. So if you want to check, this will be available, or you can just ask me. I'll send you more information on these trials. And a summary. So immuno-oncology field is growing with the speed of light. I want to show you this graph. That's the projected immuno-oncology market from 2018 to 2027. You see the huge increase in number of drug that it's planning in development now, and it's planning to hit the market by 2027. The field is growing. Many common cancers have already implemented immunotherapy in a standard of care. And because of tremendous diversity and rarity of sarcomas, as well as lack of funding, we don't really have a lot of standard of care with immunotherapy for sarcomas, but yet there is significant progress in bringing immunotherapy to sarcomas, including EHE. Currently, there is no reliable predictive biomarkers for EHE, and response of immunotherapy is mixed. It's apparent that it's not a silver bullet, and not every patient is a good candidate. However, we know that some EHE tumors demonstrate cellular and molecular features associated with good response immunotherapy in other cancers. That's promising. There are documented cases of good response of EHE to immunotherapy. That's a good sign. And that EHE's community is committed to support ongoing research to identify best immunotherapy treatments and to predict best biomarkers, figure out best biomarkers to predict potential responders to immunotherapy. Well, thank you so much for your attention. I'm going to stop sharing my screen. I'm willing to take any questions or comments, please.
And Jane, if it's okay, I'll spend less than a minute raising one additional point for the audience here, and then we dive into Q&A. So my background is in kind of scientific research. I work with a lot of cancer researchers. And I can also say, outside of the clinical trial work, there's a lot of development right now on sort of the next generation of immunotherapies as well. So there's quite a bit of research going on. Just as an example, when you hear about checkpoint inhibitors, which is, as Jane mentioned, one of the leading areas of immunotherapy, you hear phrases like PD-1 and CTLA-4. These are the molecules that are being targeted, and as we're shown in Jane's picture there. Right now, those are the 2 main ones that are in clinical work right now with immunotherapy, but there's many, many more in the pipeline, and some of them actually look better, potentially, we won't know until they're tested, than the current ones. So there's also a lot of promise longer term in the future here for just more options that will likely work on more types of cancer, that'll allow infiltration better. There's going to be more of a menu of options. So even if some of the things right now aren't optimal for EHE, there's more things coming online that may be. So there is a lot of promise in this field. I'll stop there and turn it back over to Jane for Q&A.
Any questions? You can either type them on any updates in Canadian research. No. No, it hasn't started yet. The Canadian research. I actually forgot something. I apologize. I want to share my screen again. And I want to say a few words about the next meeting, next community connection meeting. On November 12th, also at 3 o'clock, it will be a presentation of Dr. Tamara Vessel and Dr. Maeve Beckler. For those of you who have not attended their previous, I really encourage you to attend. Dr. Vessel is an amazing, we're all long for those amazing, caring doctors for whom patient is above everything. And that's what Tamara Vessel is. She is a chief of division of palliative care. She's a professor of medicine at Tufts University. She's a big shot. She was actually the one who published the article that I sent to so many patients about how effective intravenous ketorolac, intravenous anti-inflammatory drug for pain management of pleural EHE. And she takes her time on Saturdays afternoon, and she just wants to give. She just wants to give to the patients. She's amazing. She's very caring, and she's extremely holistically, like, she doesn't deliver you dogma. She will talk about what your place, how you can look at yourself and your cancer, how to psychologically accept it. It's really worth attending. And of course, Dr. Maeve Beckler, she's godsend. Well, I hate to say it because I don't want to EHE on anybody. She is an EHE patient, but she's a physician and she's life cancer coaching. She's done excellent job. Several EHE patients who are using her services rave about her. So that's something that I really encourage you to try to attend. And of course, we'll have our EHE chat on November 19th. I want to kind of mention the difference because some people ask. So the difference between EHE community connection meetings and EHE chat is that EHE community connection meetings are kind of presentation, right? We get a topic and we talk about a specific topic. EHE chats are just, let's get together and talk about whatever we want. And some people really enjoy it. I always enjoy it. It just to me, it's just getting family together over Thanksgiving dinner. All right, so I'm sorry, I forgot to show you this slide. Okay, okay, I see some questions.
And maybe I'll read them so everyone can hear, if that's okay. I'm just going to take them in the order that they appeared here. So the first one is, if you have no tissue sample, can you find out anything from an ordinary blood sample?
Well, it depends what you're looking for. Like, for example, now you can't find out anything about whether this patient will respond to immunotherapy. No, we don't have any liquid biomarkers for immunotherapy. But there is some liquid analysis that can tell you if each patient has additional to the main oncogene mutations. Some commercial companies are doing this liquid biopsies, but not in terms of immunotherapy, no.
And I will note on the research side, people are looking into that. So that may be something we have in the future.
Right.
All right, the next question. What are the key types of probiotics which will help to support the efficacy of immunotherapy?
So, when I was working on this presentation, it was very tempting for me to show the slides from the conferences where they actually name those probiotics. But then I realized they're different for different immunotherapy. So because there is also some negative effects of certain probiotics on immunotherapy, I didn't feel comfortable doing it. Whoever is interested, I can send you those. I'll make a screenshot from the conference from presentation. Again, unfortunately, today there is no one or two probiotics that definitely help with any type of immunotherapy. Different clinical trials show different type of probiotics. The consensus is if you want to maintain good microbiota, you should probably aim at multiple strains. You know, all probiotics, when you buy, they tell you how many strains. The one that I buy for my son, I think it has 32 different strains. I don't know if it does anything, but that's the best I can do today.
All right, the next question. Is immunotherapy alone a good approach to look into if currently on an active surveillance approach?
Well, again, remember, two things. First of all, I'm not a clinician, so that's not something that I'm comfortable giving advice. That's just from my perspective. All immunotherapy drugs, at least so far, they have side effects. Some of them milder, some of them more severe. They're not harmless drugs. If somebody is not progressing without understanding how you're going to monitor the effect of this immunotherapy, I understand this question. And to me, it's really appealing. What if we come up with some immunotherapy maintenance, right? Some low dose of something that doesn't have any side effect, just to keep EHE under control. Very appealing. But unless we're going to come with reliable biomarkers of knowing if it's doing something to your body, I don't think it's a good idea, simply because everybody has some side effects with immunotherapy. So introduce a patient to side effects without knowing that something good will come out of it, I don't think it's a good idea.
Next question, that might be partially related to that. Has immunotherapy been tested on indolent EHE?
So let's just make sure we're all on the same page. The EHE is divided in two categories. It's stable when nothing is growing, or slowly growing. Those two subtypes both consider indolent EHE. So the answer is no for stable. There is no, I don't know anyone who would undergo immunotherapy for EHE that was completely stable. The answer is yes to slow growing. Yes, we have patients. This is actually the patients in Sloan Kettering. I know at least 3 of them had slow growing EHE, and they had positive response for immunotherapy.
The next question, getting back to the probiotic topic, any probiotics specific to nivolumab?
Again, Tyler, I will just give me some time. Let me look through the conferences, through the trials. I might find something. Of course, I don't remember on top of my head, but I'll look for that.
All right, and then we have what type of side effects are associated with immunotherapy as opposed to chemotherapy, sirolimus, or other types of drugs?
Some of those side effects overlap. Again, because I'm not an oncologist, I kind of familiar with it, but of course I won't be able to give you the entire list. But most of the side effects associated with immunotherapy are associated with increased inflammation in your body. People become prone to pneumonitis. Some people develop inflammation in different organs, in a liver or in pancreas. Pancreatitis is quite common in immunotherapy. People experiences agitation of the arthritis, right? Anything that has something to do with inflammation can have profound effect because of immunotherapy. Again, I'm sure there is more, because I know it can affect your blood work and affect platelets, but most of them will be connected with drastically increased inflammation in your body.
Next question, are there any current immunotherapy trials open to Canadians? So I guess not necessarily in Canada, but open to Canadians.
I don't know. I think most of clinical trials in US are usually open to US citizens, but that's probably something worth checking. And I honestly, I have not looked at outside of US clinical trials, because I know in Europe they fall under under different categories. They usually not, they will not be called for EHE, they'll be just for a lot of sarcomas. And then you have to look at the exclusion and inclusion criteria. So I'm sorry, I simply don't know.
That's all the open questions right now. If anyone else has any, feel free to type in a chat or raise your hand and feel free to ask in person live.
I have a question for everybody. So to me, this is extremely important. And I cannot tell you how many hours I put into preparation of this. And it gives me tremendous satisfaction to do that. But I want to know if what I show and how I speak about it is something that you had expected, anticipated, and something that you feel is the best format. And I want to know for the future. So if you could just give me some feedback, like, do you think that it was too technical, not technical enough? If it did not contain some important information that you were looking for, just so I know for future how to modify those presentations. Any feedback I would really appreciate.
And I'll jump in and give you some comments because I attend lots of scientific presentations. In my view, that was one of the best jobs I've seen in balancing, a very technically complicated topic and making it accessible. I thought that was just amazing.
Thank you. Oh, okay. Thank you so much. Thank you so much. Again, I was not asking for, tapping on my shoulder. I really want to know if I can improve it, because it's very important to me. Thank you. Thank you. Well, I'm glad. But again, you always can private message me. You can email me. It's very simple, jgutkovich@gmail.com. Any suggestions about what else you would like to hear, right? Because I have tons of information on EHE. Like my EHE collections is more than, I don't know, 2,200 articles, and they're all systematized in specific collections. If you have specific interest, and I'll get enough people that show interest in a specific topic, I'll be happy to do a presentation on a specific topic, like literature review with some scientific or like clinical background. Please feel free to reach out. I'm happy to do that. I love to hear about gut health. Yeah, me too. So I'm really looking forward to this day at Immuno-oncology, and that's my greatest interest now. And you know what, I was like laughing because I said, well, very soon our biobank will start collecting poop samples. We'll just go to the patients who responded well to immunotherapy and just, come on guys, send us a few stool samples. Well, if it's between getting chemotherapy that's so toxic to your body and getting a little stool sample from another person, I'll go with that for sure.
And I'll throw out a request as well, sort of more generally from the EHE Foundation. If there are topics, Jane can answer questions on many, many, many topics, but we do have access to lots of researchers and clinicians. So if there are other topics where you'd want us to bring in additional people to speak as well, let us know what those topics of interest are.
Yeah, and actually, I was planning to bring a physician to this topic, and I approached several physicians at the Sloan Kettering, and unfortunately, they couldn't make it. It's always, you have to give them like at least 3 months ahead of time. But they were willing to do that. They apologized for not being able to, but in the future, that's definitely a plan to bring physicians.
And I see Denise Z posted a really interesting topic here. So more information generally on generally living with chronic cancer would be fantastic, such as gut health, diet, et cetera. It's a really good question. When you've got a disease that's chronic, where people may be taking medication on a chronic level too, that can affect liver health and things like that.
Absolutely.
I think it's a great topic on, what can you do to,
yeah,
have a healthy 30-year run.
Yeah, I really suggest you to attend Dr. Vessel presentations, because that's right up to her alley. It's so difficult to cover this topic because, you know, when it comes to immunotherapy, I go after facts, right? I can look up clinical trials, what they showed. I can look up how certain types of immunotherapy works. When you're talking about this topic, there's so much out there, and it's so hard to translate it into the EHE, because, you know, so we can try to do that. I would be actually much more comfortable bringing an expert in the field than doing it myself, because again, there is no solid data on that. It's only what somewhere in other cancers, everybody's different. You know, one thing I realized about EHE, and I don't know if you'll agree with me, David. So when I worked in cardiology for 30 years, and I got used to everything is variable in cardiology. Like, you know, doctors have a huge variety of drugs. They try this, it doesn't work, they try that. I see some patients that, technically speaking, I don't understand how they still live, because they don't have a heart. Their heart is just, you know, rarely moving. And we have young people totally healthy that all of a sudden get massive heart attacks. It's extremely host dependent. I get a feeling that when we talk about EHE, we talk about cancers. Cancers are much more predictable because they're aggressive. It's an aggressive disease that can be predicted. But when we talk about EHE, it is so much host dependent. Unless it becomes very aggressive, then we can predict it. But all those indolent, slow-growing EHEs, totally unpredictable, because they depend on your own immune system, your own genetics, your own diet, your stress levels, your sleep patterns, so many variables that it's totally impossible to predict. So when we're talking about living with chronic cancer, then we're going into this, who we're talking about? Are we talking about patients on a lot of painkillers that really suffering, and, you know, they need this, this, and this? Or we're talking about people who totally pain-free. They just know that they have cancer, and they undergone this anxiety several times a year. It's different population of each patients that will need different approach.
Yeah, I think you know, especially with these are hard things to study, and it's not generally the focus of where a lot of people put their research dollars. And with EHE, where the numbers of patients in the world are so small, that you probably cannot actually run meaningful studies to answer those types of longer term questions. So I think you're right. And for a lot of people, you know, working with their clinicians, where the clinicians can help, and some will be more helpful than others. But also, you probably, I mean, it seems unfair that this might be the answer, but, you know, experimenting with yourself to see what makes you feel better, and you know, and what works for you with diet, and what works for you, and then, you know, just keep listening and watching, and as we learn more out there, you can probably learn some things from other cancers, but we just don't have the numbers in the EHE to conduct the types of studies necessary to definitively answer those questions for EHE. So I think we have to do the best with what we have. And I do think people are very variable person to person.
Yeah. You know, I'm actually teasing. I'm crying, because I just realized that Jolene Reddish is the person who is so important to me, who's been with me and us for many years, and a very important person in my life, asked, can we help with anything? Can we help with gathering information for the foundation? I help with reading articles in the past, with reading articles in the past. Jolene, first of all, it's amazing to see you here. Thank you so much for keeping with us and remembering us, and thank you so much for offering help. We'll keep it in mind. Thank you so much. I see that other patient asked about ICANNA trial. No, there is no information on ICANNA trial, and we will not have this information almost to the end of a clinical trial. Everybody hates it, except David, because he's a lawyer. I'm kidding. Everybody hates it that you cannot get information on what's going on in clinical trials. They're not allowed to share it. So we will not know much till probably almost the end of the clinical trial.
And in fact, most trials, the way they're run, you won't know. Now, in some cancer cases, you do kind of anecdotally as you're watching patients, but in general, because the studies are double blind, the true answers don't get revealed until the very end, although sometimes you can get a hint.
Yeah. You know, I'm hoping actually that like just this morning, I spoke with the patient who is in clinical trial for immunotherapy, and he gave me some information about his response and how he feels. I'm not comfortable sharing it here, but I'm kind of hoping that people will post on Facebook and share the experience, because that's the only way we can get a sneak into how people are doing in this clinical trial. So the more people will have on clinical trials, the more information we'll get. I also want to mention something that when I invited Dr. Sandra D'Angela, she's the head of research at Sloan Kettering, and she's a big immunotherapy person at Sloan Kettering. She was actually the first one that I invited to join this meeting. She couldn't, but she gave me something interesting, something new perspective. For many years, the clinical trials were designed when people tried different treatments that are already established, right? That FDA approved, that standard of care. And only after they failed this, then they offered clinical trial. There is a new wave now that clinical trials are offered to patients at the very beginning, especially if there is no standard of care. Like we know for EHE, there is no standard of care. And all those drugs that actually doctors offered for EHE, they're not effective for 100% of patients. Some patients respond, some patients don't respond. She feels that at the very beginning, the clinical trials should be offered to sarcoma patients, including EHE, just as another option. So people have another option. And she said she's very honest with the patients. She said, I always tell them, we have no idea if it's going to work for you or not. But the same with other drugs. When doctors telling you, let's put you on pazopanib, or let's put you on gemcitabine, they don't know if you're going to respond or not. So I really like this new philosophy. Let's offer clinical trials to the patients at the very beginning. But the patients should not think that because doctor offer it to them, it means that nothing else will work. Like the clinical trial is the last resort. No, it's just one of the options, and very often it's an equal option. I thought it was great innovation in clinicians' approach to clinical trials.
All right, I'm not seeing any other questions. I think we have about 10 minutes left if there are additional questions. We may be at the end then.
Okay, great. Well, thank you so much. I hope you'll come next Saturday. Not next Saturday, I'm sorry, the 19th to the 12th to hear the presentation of Dr. Vessel. It's not even a presentation, you know, it's like, to me, it's like a therapy. Like she's a great therapist. It's a conversation. And thank you so much for your time. Thank you, thank you, thank you.
Yeah, thank you everyone for attending, and thank you for your contributions here. It always
And
makes
remember,
these better.
those slides will be recorded, so so you'll have an access to this presentation if you want to go over. And I am always available to answer more questions and to go a little bit more in details if somebody's interested.
Just a quick note, we will make the recording available, but the sessions with Drs. Vessel and Beckler are not recorded because they are kind of more like a conversation or a therapy session. So those ones are just very intimate. They're wonderful. So highly recommended for sure.
All right, bye. I'll have
Great.
a good day and weekend.
Bye, everybody. Good night, good morning, good evening, wherever you are. Thank you. Bye-bye.